All right, diving into the world of pleural effusion in the ICU today. And wow, this World Journal of Clinical Cases article is packed.
Absolutely. It's a topic that deserves a closer look, that's for sure.
Definitely. So, pleural effusion. For those of us who don't spend all day thinking about lungs, can we start with a quick picture of what we're talking about?
Sure, think of it this way. Your lungs are like balloons, right?
Okay, I'm with you.
And your chest cavity, that's like a container. Pleural effusion is when you start pouring water, we'll call it pleural fluid, into that container.
So the fluid builds up around the lungs.
Exactly. And just like those balloons would have a harder time inflating, the excess fluid makes it tougher to breathe.
Makes sense. But there's always a little fluid in there normally, right? It's not like it's supposed to be totally dry.
You're right, there's always a small amount, a thin layer, that acts as a lubricant, so everything moves smoothly with each breath. It's when that fluid starts to build up beyond normal that we run into trouble.
Especially in the ICU, as this article highlights. What is it about that environment that makes pleural effusion such a challenge?
Well, you've got critically ill patients, often with weakened immune systems, making them more susceptible to fluid imbalances in the first place.
Right, their bodies are already fighting so many battles.
Exactly. And then you factor in things like mechanical ventilation, which can disrupt the pressure balance in the chest.
And many of these patients are on prolonged bed rest, which can't help.
Unfortunately not. It can actually worsen fluid pooling. All of these factors create a perfect storm for pleural effusion to develop.
And this isn't just about some extra fluid. The article really drives home how tricky it can be to even diagnose pleural effusion in the ICU.
Oh, absolutely. It's not always straightforward. Traditional methods like chest x-rays, they can be helpful in other settings, but in the ICU, not so much.
Why is that?
Well, patients are often lying down, which can obscure the fluid on an x-ray. Plus, the symptoms of pleural effusion can be masked by their other underlying conditions. It's like trying to find a needle in a haystack while riding a roller coaster.
Wow, yeah, that's a chaotic haystack. So what's the solution then? How are doctors getting a clear picture?
Ultrasound. It's become an absolute game changer.
Like a superpower for seeing inside the chest.
You got it. It's like having a high-powered flashlight in a dark room. Doctors can see even tiny amounts of fluid right there at the bedside and get a sense of its characteristics, which we'll talk about later.
Okay, so we're starting to get a handle on diagnosis, but before we jump into treatment, let's talk about why this is such a big deal. Why is catching pleural effusion early so crucial, even if it seems like a small amount of fluid?
That's a really important point. It's all about breathing. That pleural space, that potential space, it's crucial for the lungs to expand and contract properly.
Yeah.
When you get that excess fluid in there, it's like, imagine trying to blow up a balloon that's already under a ton of pressure.
Right, it's going to be much harder to inflate.
Exactly. And for a patient in the ICU who's already working so hard to breathe, even a small amount of fluid can have a huge impact.
Makes you realize just how delicate that balance is.
It really is.
Yeah.
And as the article points out, the problems don't stop there.
Yeah.
This can actually set off a whole cascade of issues.
Like dominoes.
Exactly. Take weaning off a ventilator, for instance.
Yeah.
That's a huge milestone for ICU patients, a sign of recovery, but pleural effusion.
Makes it that much harder.
Exactly. Their body's already struggling, and now it's like asking someone to run a marathon with a weight vest on.
And staying on the ventilator longer, that comes with its own set of risks.
Absolutely. Increased risk of infections, lung damage, you name it. And it's not just breathing. This can impact heart function, lead to longer ICU stays.
And ultimately affect their overall prognosis, as the research mentioned.
Exactly. So we're not just talking about a bit of discomfort. We're talking about potentially life-altering consequences.
So this isn't something you can just monitor and hope for the best. It sounds like early intervention is key.
You hit the nail on the head. The name of the game is early diagnosis and prompt treatment to prevent those downstream effects.
Which brings us to the treatment side of things. The research paper really dives into drainage as a primary method. Can you walk us through why that's so effective?
Sure. Think of it like a car tire with too much air, right?
Okay, I can picture that.
It's going to be stiff, unforgiving. Drainage is like letting some of that air out. You're relieving pressure, allowing the lungs to function the way they should.
Essentially releasing the pressure valve?
Precisely.
Yeah.
But of course, as with any medical procedure, there are risks involved. The article does mention things like pneumothorax, which is a collapsed lung, bleeding, those sorts of complications.
Right, so there's always a trade-off to consider.
There is, but here's the crucial thing. For a patient in the ICU who's already incredibly sick, the potential benefits of drainage usually outweigh those risks.
A calculated risk, but a necessary one.
Exactly. And thankfully, we have some great tools at our disposal these days. The article highlights pigtail catheters, which offer a less invasive approach to drainage compared to traditional chest tubes.
So smaller, more comfortable for the patient, but still effective.
Exactly. You're still achieving that goal of removing the excess fluid and taking the pressure off the lungs.
But, and I'm guessing this is where the real detective work comes in, it's not as simple as just getting the fluid out, is it? It's like that fluid holds a story, right? Like it can tell us what's really going on. The article talks about analyzing the fluid, and I don't know why. It makes me think of those crime shows where they're like dusting for fingerprints.
It's a good comparison, actually. Analyzing pleural fluid is kind of like piecing together a puzzle.
So what are the pieces they're looking for? What's going to give them the aha moment?
Well, one of the first things is figuring out if it's what we call a transudate or an exudate.
Okay, gotta admit, those sound pretty technical. What's the difference?
So think of it this way. A transudate, that's like, imagine water leaking through a pinhole in a pipe. It's mostly clear, watery fluid that got pushed out because of pressure changes.
Okay, so more of a mechanical issue.
Exactly. Often points to problems like heart failure, where the heart's not pumping efficiently, or liver disease, something affecting that fluid balance in the body.
Makes sense. So what about the other one, the exudate?
That one's different. Think thicker fluid full of proteins and cells. It usually means there's inflammation or damage happening right there in the pleural space itself.
Ah, so it's not just pressure. Something's irritating that lining.
Exactly. Infections like pneumonia, inflammatory conditions, even cancers affecting the lungs or pleura can cause this kind of fluid.
Wow. So just by looking at the fluid, its color, thickness, what kind of cells are in there, doctors can get a much better idea of what's causing the problem.
Exactly. It might not be what they initially suspected at all. In fact, the article mentions this really interesting case. A patient came in, shortness of breath, chest pain, a large pleural effusion.
Sounds serious.
Well, it was. Everyone thought it was a pulmonary embolism.
A blood clot in the lungs. Yeah, that's a big deal, especially in the ICU.
Exactly. But then they analyzed the pleural fluid and find high levels of an enzyme called amylase.
And that told them.
Pancreatitis.
Yeah.
Inflammation of the pancreas, not a pulmonary embolism at all.
Wow. Talk about a plot twist.
Right. That one test on the fluid completely changed the diagnosis and, most importantly, the treatment plan for this patient.
It's amazing, really. It's not just about getting the fluid out, it's about the information it holds.
Couldn't have said it better myself.
Yeah.
And it makes you wonder, in those cases where drainage doesn't seem to improve a patient's outcome, even when you adjust treatment based on what you learned from the fluid, what else could be going on?
Yeah, what's the missing piece of the puzzle there?
The article touches on this.
Yeah.
There was a study where some patients, even with drainage and adjusted treatment, did do as well.
So even with the fluid gone and the right treatment in place.
It makes you think. It could be that the effusion itself or the underlying condition had already caused too much damage at that point. It could be something specific to the individual patient that we don't fully understand yet. It's a good reminder that even with all the advancements we've made in medicine, there's always more to learn.
Always more questions. It's like each case, each sample of fluid is a chance to learn something new.
Absolutely. And ultimately, that's what it's all about, finding better ways to care for our sickest patients.
I think that's a perfect place to wrap things up. A huge thank you to you, our expert, for taking us on this deep dive into pleural effusion in the ICU. For our listeners, thanks for joining us. We'll catch you next time for another deep dive.